هنبتدي اول حاله بس بعد اذنك.
هي باينه على السكرين. هي طلعت على السكرين.
هي اول حاله ان شاء الله هتبقى عن الستيجنج في بريست كانسر ان جنرال. بيشرفنا في البرزنتيشن دكتوره ايمان علي ودكتوره صافي حسني، دكتوره رشا حسين، دكتور محمد فتحي. اتفضلي يا دكتوره ايمان.
Yes. Our first case presentation, she's 54 years old, female patient, premenopausal, ECOG1 with negative family history and past history. The condition started while she was under annual screening since 2020. In July 2022, she presented to the clinic complaining from breast lump. On examination, she had hard palpable left 12 o'clock mass with no palpable axilla, clinical T1, clinical N0. Breast sonomammography was done. Dr. Hussein.
The patient had heterogeneous breast parenchyma ECRC, and there's a distortion or speculated obscured mass at the left breast between 11 to 12 o'clock. Ultrasound. Also, the ultrasound showed the speculated hypoechoic mass, and the next image, it's about the axilla. It's negative, non-specific axilla. The patient, we recommend to do a contrast-enhanced mammography because the patient had dense breast. There is the heterogeneous speculated enhancing mass corresponding to the distortion seen in mammography.
After that, our patient underwent ultrasound-guided core biopsy.
It is a straightforward case of invasive duct carcinoma grade 2. We can see in the first H&E slide irregular groups entropically of malignant ductal epithelial cells. It was strongly positive for both ER and PR, and HER2 was negative 1+. Ki-67 was 10%.
Now we have a case of 54 years old, premenopausal, presented by clinical T1CN0, luminal disease. Dr. Muhammad, about surgical plan للعيان.
MD decision was wide local with sentinel, so we proceed for left wire localization. Lesion more or less not well palpable, so wire localization was done. Wide local excision with sentinel lymph node was done. Post-operative pathology.
The case was diagnosed as mixed invasive duct and micropapillary carcinoma grade 2, stage T1C. The gross tumor size was 1.5 by 1 centimeter, and lymph nodes were negative 0/10, lymphovascular emboli were prominent. As we can see in the histological pictures, first photo shows both patterns presented almost equally, 50% micropapillary and 50% invasive duct. Second photo shows the lymphovascular emboli, where a group of tumor cells are present within an empty space lined by flattened endothelium with some RBCs, proving that this is a true lymphovascular embolus and not just an artifact. The last photo shows the micropapillae forming cluster within empty spaces characteristic of the micropapillary pattern. Just to mention that invasive micropapillary carcinoma have lymphovascular invasion and axillary nodal mets seen more frequently than the classic type of invasive duct carcinoma. Therefore, this is why I mean that micropapillary morphology is associated usually with a worse prognosis.
To summarize, now we have a case of 54 years old, underwent left wide local excision with mixed invasive duct carcinoma grade 2 with micropapillary carcinoma T1C 1.5 centimeter, node negative, luminal disease ER/PR 8/8, HER2 was negative with lymphovascular invasion, and Ki-67 is 10%. So our patient, she was for adjuvant tamoxifen and post-operative radiotherapy, but unfortunately, during the CT simulation, we accidentally discover bilateral subcentimetric lung nodules. As we see, it is about 2 to 7 millimeter bilateral subcentimetric lung nodule accidental discovered during CT simulation. So our first question to the panelists, what is the next investigation for this accidental discovered bilateral subcentimetric lung nodule, PET-CT or guided biopsy from lung nodule, or just to consider being metastatic and go for palliative treatment?
Thank you, Dr. Iman.
I will ask a question before considering after discovering that the patient is metastatic, Dr. Iman. Did this patient require staging before starting the before going into the surgery? What?
The case again is early T2 and 0 and luminal disease and
T1
started
and 0. T1
and 0 and started upfront surgery without staging.
No, this patient do not require any further investigation before going to surgery.
Okay.
I agree, but any patient who go to any oncologic department should receive at least X-ray chest as a mandatory, regardless of the stage of the disease. So the minimum requirement here is X-ray chest. You don't need CT scan, you don't need bone scan or PET scan, but X-ray chest is mandatory regardless of the stage.
For the aim of staging or for the aim of...
No patient can be treated without X-ray. This is a standard in medical practice. Screening profile lab should be done all the patient. X-ray chest should be done and good past history. Especially in the area of COVID, you have to take a good history from the patient.
So I'm again focusing about the concept of X-ray chest is to avoid screen for COVID or for staging. Yes. Okay. So all of us again not for staging.
I think she will go for X-ray before surgery. صح?
No. We don't do routine X-ray before
surgery. I want to
surgery.
hear from the surgeon. لأن أنتوا بتعملوا.
I think this patient only need alkaline phosphatase. This is no need for any investigation as metastatic workup. This early stage, no need for any investigation except alkaline phosphatase.
So may I ask what was the post-operative pathology size? The size of the tumor post-operative size?
1.5 centimeter.
Okay. Yeah, so the reason I asked is because on mammogram, there was distortion. So what we would do normally is do an MRI scan of the breast. If the tumor size was T3 range, and it's not, then we would do a CT staging scan. Otherwise, for her, we would not do anything, including bloods or chest X-ray. But that's UK practice.
So Dr. Rasha, did we do MRI first for this case or because it's dense breast? Or any contrast study, as Dr. Agrawal asking about the distortion surrounding the main mass, may upgrade the stage, maybe T3 lesion or still it's T2 lesion, the T1 lesion. So
can I comment on this?
Distortion seen on mammography is corresponding to the mass seen on contrast enhanced mammography. We just recommend the MRI when there is a certain location of the lesion that is the making MRI. Otherwise, if it's available contrast enhanced mammography, we can start with it.
Thank you. Dr. Yazan, have a comment?
So I completely agree. Contrast enhanced mammography is exactly like MRI scan. It's a functional image, so we don't need an MRI scan for this lady. Where I work, we will not do a chest X-ray at all, unless you do chest X-ray to scan for something that is here different than the UK. We don't do chest X-rays preoperatively. And even if you do the chest X-ray, I know that you're saying that that's not going to be done for staging. I don't know if you do it to screen for TB or screen for anything else. Then that's the case, that's fine. But in the UK, we will not do a chest X-ray routinely. So don't do it for the cancer, you do it for some other things.
Thank you very much. My second question, after the surgery, the patient has been discovered to have invasive micropapillary carcinoma, which has an aggressive biology. Now, do you recommend to go for CT staging after discovering it has an invasive micropapillary disease? Anyone wants to recommend?
يمكن هم اثنين تيومرز احنا في اللاست ديكيد احنا بنهتم ان احنا نكسبلور ذم مايكرو بابيلاري اند ميتابلاستيك كارسينوما. الاثنين دول ستيل انا ما اقدرش اقول ان الساينتفك كوميونتي بدا يعرف فيهم حاجه كتيره دي، لكن مايكرو بابيلاري شهيره باكستنسيف ليمف فاسكولار امبلاي، هاي انسيدنس اوف نود بوزيتيفيتي اند اجريسيف بيهيفير. لو انا هختار مين اللي اعمل له او اشك فيه جامد اللي ما اعرفش عنه حاجه. اللي I know no aggressive لكن I don't know its behavior. If I have a T1 micropapillary tumor I will هفترض ان هو metastatic already and هعمل full metastatic workup especially micropapillary and metaplastic triple negative.
Okay. Another question, please.
This is our second question.
Okay, Dr. Hussein.
Allow me to Maher. I think according to NCCN guidelines, staging is just for the T and the N and the M. Whatever the molecular subtype or the pathological subtype of the lesion. We know that some lesions are more aggressive than others, but still we are considering the T1 and 0 as early breast cancer. We shouldn't go for any further studies. Worth mentioning here that any CT chest, because it is part of the malpractice, any CT chest should be done with contrast, not without contrast.
Thank you, Dr. Husseini. But the main aim of this case and this session is to focus about this. The NCCN guidelines recommended there is no staging in early breast cancer in T1 and 0, but the ESMO guidelines sometimes recommend to do in aggressive tumor behavior staging, like triple negative breast cancer or HER2-rich breast cancer or the micropapillary subtypes or the aggressive subtypes. So the debate is here between the two guidelines and what will the panel will recommend.
Can we ask the presenter if they have to go for the staging in aggressive pathology? Because I think you
Dr. Amani, may I ask a question? But if I have multiple lymphovascular emboli in the case and it maybe...
It is a risk factor. Yeah.
So we shouldn't do a staging. If I have multiple lymphovascular emboli and extensive, do you recommend the staging in such situation?
Micropapillary يتساوي microvascular emboli and high tendency for node positivity. الحالة دي كان فيها بالفعل microvascular emboli بتركب بايوبسي في أول سلايد كان فيها بالفعل. فهي أنا بتكلم على invasive form of micropapillary. ده هيخليني فعلا اقول لا اشك ان ممكن تكون اعنف بما يبدو MRI was a must full staging as
Okay, Dr. Ayman.
We asked the second question already. Dr. Amani raised the question.
The first question احنا لسه ما didn't answer.
Should we consider routine staging workup in high risk T1 N0 breast cancer cases like micropapillary carcinoma, triple negative, low ER, grade 3 extensive lymphovascular invasion? Yes or no? Should we consider as a routine staging in our
Can we take a vote?
Who's with yes?
So can address in aggressive behavior tumors. Can we select some cases for staging? Can we have a vote for this?
Routine staging.
لا يعني السؤال يا اما هيبقى روتين براكتس لكن ممكن كلنا هنقول ممكن لان احنا في حالات فعلا في الام دي تي بتبقى ليها سبيشال يعني سيتويشن سنها مع اجريسيف تيومر مع كده بنقول نعمل لها وساعات حتى مش بنستنى انها تكون تي 2 او كده فهي اما يس اور نو ده يبقى روتين براكتس
or we can recommend criteria.
في يعني انت عندك كرايتيريا كتيره ممكن تدخل مش يعني لا I would say مثلا تخليها per case in MDT decision ولا روتين براكتس
بالظبط
for longer time. ده اللي اقصده. في triple negative I can say no. You can omit early stage.
والله احنا ممكن يعني في مستشفى باي عندنا كم من الحالات يمكن الدكتوره غاده تقول المايكرو بابيلري والميتا بلاستيك يعني ما بقاش بالنسبه لنا قد يعني كتير حالات كتير فيعني بس الفكره ان هو يعني ما ينفعش ان انا اقول ما انا لو دخلت دول يبقى معناها ان انا هعمل سيتي لنسبه كبيره جدا من العينين اللي هي ما هيش فيزبل يعني انا موافقه جدا دكتور حسين ان هي تي 1 تيومر تي 1 او تي 2 ان 0 يعني ايه اللي العينه يعني هتبنفت نعم ما هي بالظبط كده
Okay, who's with yes? ما حدش with yes. No, not to be routinely done.
This is our first case.
Okay. لا مش. For early disease breast cancer, whatever is the histology and whatever other risk factors, we all should agree that these patients did not require aggressive staging because the instance of having a metastasis on this staging is very low. This goes with guidelines.
Thank you very much, and thank you for the presenters of the first case.
دكتور ماهر معلش سؤال للحالة دي نفسها. Why they put a wire for this case? It was palpable.
Yes, it was palpable.
It was palpable.
1.5 centimeters. It was palpable. Single lesion and palpable.
Why you put the wire?
احنا كتير جدا many times in the MDT when there is marked adenosis like in this case she has a very extremely dense heterogeneous dense breast.
Yes.
The surgeon requests for a wire because he's never sure is that we
not palpable.
And even if palpable,
and even if palpable, as Dr. Rasha
many times the surgeon tells us, please fix a wire to make sure that what I'm palpating is the actual tumor that you are seeing, especially if it is a small tumor in a dense breast.
Okay. To consultant and both request the wire.
And so thank you very much, and we concluded the conclusion of the first case, and the next case now is about the management of oligometastatic breast cancer. Our presenters, Dr. Ahmed Arabi, Dr. Wala Abdelaziz, Dr. Safi Hosni, and Dr. Ali Kamal.
Okay, our case, a 58 years old, 58
صوت يا احمد.
اوكي
صوت خلي المايك قريب منك شويه عشان الصوت واضح.
58 years old, female, hypertensive, و negative family history. Performance status 1. She complained of a left breast lump for a year, diagnosed outside as invasive carcinoma. The examination revealed left outer mass 7 by 7 centimeter with no palpable axilla. The imaging, Dr. Wala.
By mammography, as we see here, there is upper quadrant focal asymmetry mounting to mass formation. It is ACRA, and no other lesion seen in right breast. By ultrasound, we have this large area of altered parenchyma seen extending from 11 o'clock to 1 o'clock, measured about 7 centimeters. Unfortunately, we have similar speculated lesions seen at 2 o'clock and 4 o'clock, so we consider it as a multicentric disease. Lymph node, we have multiple enlarged axillary lymph node with effaced hilum seen at level 1, level 2, level 3, with ipsilateral supraclavicular lymph node. We take true cut biopsy.
The case was referred to our lab, the slides and the blocks, and it was diagnosed similar to the original report as invasive lobular carcinoma grade 2. We can see in this image the characteristic linear files of the invasive lobular carcinoma. ER was strongly positive, PR was positive in 20% of the tumor cells, HER2 was completely negative, NKI labeling index was 30%. So what we should do next?
As this patient was locally advanced disease with T3, N3 level, we recommend CT staging. CT show no liver or lung metastasis, but unfortunately we have this L2 lytic and sclerotic lesion and request bone scan for correlation. And bone scan reveals there is uptake at L2 vertebral body. This is question for the panelists, what we should consider this patient.
Thank you very much, Dr. Amin.
This patient with locally advanced T3N3, as I remember, luminal disease, luminal B, Ki67 is 30%, and with single bone metastasis. Would you consider this patient for radical or curative treatment, or just consider his as a metastatic disease and go for palliative treatment? Who wants to comment?
Dr. Wali?
For this case, we will start systemic treatment and we will see what's the response for this case. And I think it should be run in a palliative. If there is no symptoms from the metastasis or locally, and any surgical intervention should be for palliative manner, not for curative manner. There is debate in this, but locally advanced. You will start systemic therapy and we will see what's next.
Systemic therapy will differ if the patient is considered to be a metastatic, or should we go for a curative treatment?
This metastatic disease,
metastatic. So
metastatic.
you going for a palliative treatment?
Yes, not new adjuvant.
Not new.
It is systemic treatment.
Okay, Dr. Gamal.
This is a very difficult case. There is no agreement, and this depends also on the behavioral disease, long-standing breast mass, or just appeared in few weeks. But now there is a new data about the oligometastasis. You can treat it radical treatment. You can do surgery. You can give SBRT, which is local radiation with a bone metastasis, and treat it like non-metastatic disease. If you believe it is metastatic disease, you don't need surgery. Just to need any systemic treatment with a new CDK4/6 plus bisphosphonates something.
And reviewing the picture of the patient having a T3 lesion with N3 and only a solitary bone metastasis, this means that the tempo of the disease is not that aggressive. So that's why I'll give her a chance for a radical treatment before considering her metastatic.
I would go for radical treatment. Oligometastatic, I would give the patient a chance for radical treatment.
Yeah, I agree. Go for radical treatment. The only thing interesting, which is almost contrasting, is invasive lobulars morphology, and it's Ki67, 30%.
Yes.
Usually it's they would go together, invasive lobular. So yeah, I mean, because she's T3 disease, N2 or 3, yeah, N3, yeah, certainly neoadjuvant chemotherapy with the intention to cure, but really will keep a very close eye.
Yes.
Because what if it doesn't respond in spite of Ki67 being 30%?
Okay. If you allow me to comment for the oligometastatic disease, I know we have this is a very debatable point, and you will never find all of the oncologists to agree on what should be done. So we will hear from Dr. Ahmed Amin, and then I will postpone.
Yes.
Thank you, Dr. Amini. Actually, oligometastatic is always an issue, actually. I'm sure all of us agree that this is M1 disease. So in the management, M1, yeah, it's metastatic. Even if we're considering radical treatment, it should be within some clinical trial. But the only thing you want to add that for me in my practice, I would consider some advanced imaging like PET-CT for this patient. When we order PET-CT, sometimes we discover some active mediastinal nodes, for example, or any other lesions in the bone. So this might even change the category of oligometastatic to metastatic patient, and radical treatment in this case will not be considered. So I must just add that I will consider PET-CT. Then if oligometastatic, I might proceed with radical treatment within clinical trial.
هو دكتور أحمد, that's actually what we do in Baya. Before deciding that she's treated radically, we do a PET-CT just to make sure that there are no other sites of metastasis.
If the patient has a single bone lesion and she is luminal, she might deserve going to some sort of radical treatment. Especially she comes with synchronous treatments. As Dr. Amani said, the patient is T3N3 presented with only single bone mets. It's not that aggressive disease. after طبعا ده لسه اللي كان الكومنت التاني ان احنا when we start systemic treatment usually we should look for the response to the
Yes.
treatment. If she's not responding, I think all we can agree she can go for palliative treatment. Anyone wants to comment?
So we can consider it is consensus that the cases with oligometastatic, by definition of oligometastatic, less than 5 sites, and it's preferable to be the bony sites with neoadjuvant chemotherapy first, and good response to neoadjuvant chemotherapy, and then you can control the site of mets either by radiation therapy for the bony mets or by radiofrequency or excision for the visceral mets. So you can manage these cases as a with curative intent, yes or no?
I can just comment. I'm not totally agree with the visceral disease. I can agree with the bone mets, but with the visceral disease, I'm not that big fan of going into radical treatment for a patient presenting with lung or liver mets.
Actually, Dr. Amani always say that I prefer to consider this concept only for the bony lesions. It is very durable and responsive to the treatment. But sometimes we find patients with single liver nodule that is about 2 centimeters, and we have to consider it oligo or not, and this is a debate. So, Dr. Muhammad?
Oligometastasis refers to presence of metastatic sites from 1 to 5. The definition of oligometastasis اختلف. هل أنا بتكلم على 1 to 5 sites in a single system? And I mean by a single system musculoskeletal، يعني لو أنا بتكلم على rib, bone and so، ولا بتكلم على viscera؟ زي ما أنت بتقولي دكتور أماني، they excluded not viscera, only lung. Multiple metastases 1 to 5 sites in the lung were excluded from your conclusion. I will go for this in any 1 to 5 sites in single system excluding the lung. ده آخر meta analysis.
Okay. So the concept itself by to treat the patient with curative intent, that Dr. Walid Nahas will not agree. So, but I think it's better for the patient to give him here this option in. But we see some cases or many cases with long-term follow-up without any recurrences and treated as oligometastatic condition.
كنت هقول كده if the patient presented with liver and she maintained the response for a long time, now we can consider the local treatment and the radical treatment, but just for immediate response, that's my opinion. Of course, I just want to hear from all of you. If she bone metastasis, yes, I go with radical. Visceral needs case by case.
So you do recommend it to give the radical approach in bony only, not visceral?
I'm a pathologist, by the way. Do you expect to have pathologic complete response in that patient? I think not, because of the luminal type and because of the low PR and high ER. So definitely no pathologic complete response in this case, or at least 90%.
Yes, I think just we look for a response to treatment, not progression. Just the response, any type of response. But the patient, if progressing after neoadjuvant chemotherapy.
Can I ask the oncologists, if you are not treating in aim of cure, will you give her chemotherapy up front or just give her CDK4/6 and monitor?
Sorry?
So if you're not treating her aggressively, you're not giving her chemotherapy in view of surgery, in view of giving her radiotherapy to the bone. What will you do? Will you consider, if it's in a palliative setting, will you give her only CD4/6 and don't do anything for the breast? What will you do?
If she is palliative, yes, we are going to CD4/6 plus hormonal treatment. If I went to surgery, now I want to treat the patient radically. This is the case for all of metastatic disease. We leave the primary to respond as long as the metastasis to the systemic treatment. I think you have another opinion, and I can hear it.
Dr. Nadia, you have a comment, Dr. Nadia? Dr. Nadia, have a comment.
No, I don't have. I said that this patient will not reach a pathologic complete response.
So you can conclude.
Okay, now to conclude, who's with going into the radical treatment in this case with the breast cancer single bone lesion? Yes.
Yes, I think it is. The concept itself is acceptable, and the selection criteria should be an MDT per MDT.
Okay.
Thank
And
you.
now we want to hear what's happening with this case. Please, A.
MTT decision was oligometastatic case for neoadjuvant treatment followed by bone scan to assess response, then modified radical mastectomy. Patient received full course neoadjuvant chemotherapy in form of 4 cycles AC followed by 4 cycles taxotere.
After the patient finished her treatment, we have a PET scan to see what happened at level of L2. As we see here, still grossly there is a lytic lesion, but no FDG uptake that confirm that we have complete radiologic complete response at this level.
The patient did left modified radical mastectomy, and grossly we saw 2 masses, upper inner quadrant 1 and upper outer quadrant 1. They were 2 centimeters apart, and the least deep clearance was 7 millimeter. Largest lymph node was 2.5 by 2.5 centimeter. And this is the microscopic picture. And as Professor Dr. Nadia Mukhtar said, there was a poor therapy response. Viability was 80%. We can see the sheets and linear files of rather monomorphic discohesive malignant epithelial cells. There was no any associated lymphovascular emboli or DCIS or Paget's disease. This is a picture for the nodal metastasis post-therapy. We can see that there is complete distortion of the normal nodal architecture with hyalinization of the stroma with residual viable tumor cells. And here we can see the extra nodal extension, perinodal fat infiltration detected. And the right-sided inset, we can see the signet ring cells characteristic of invasive lobular was found within the lymph node mets. So the case was diagnosed as being multicentric invasive lobular carcinoma, grade 2, T2N2 post-chemotherapy, residual cancer burden class 3, resection margins were free, and axillary lymph nodes were positive for metastasis with perinodal fat infiltration and partial therapy response. Patient received post-operative radiotherapy left chest wall with supraclav using 3D radiotherapy, followed by stereotactic radiotherapy to L2 vertebral body treatment, ended 30 March 2022. Patient started the systemic treatment in form of anastrozole since January 2022, plus Zomita every 3 months. Patient is still in follow-up after 10 months of systemic treatment, anastrozole, and CT still free from distant mets, and follow-up bone scan show regressive of L2 vertebral lesion with no newly developed lesion in the bone.
Okay, the question. My question will be to the medical oncologist, and Dr. Amani is ready for that question. What is it? Do you consider AI is a good treatment, or she should receive another?
Should receive the CD46 inhibitors in addition, based on Monarch E, adding abemaciclib as having 4 lymph nodes positive and Ki-67 more than 30%. She deserves to receive the abema in addition to aromatase inhibitor.
Do you agree, Dr. Gamal?
This is a very hot debate. The study of Monarch E did not include patients with oligometastasis, but extrapolation from the study. And as we are familiar now with the abema as an aggressive treatment, I agree with Dr. Amani, particularly this patient, to give, although we don't have a study to confirm that, but I think abema for 2 years will be good. So you cover her whether she is metastatic or non-metastatic.
Any other opinion before giving my opinion, if you don't mind? Okay.
معلش يعني انا بالنيابه عنكم بشكر الدكتوره ناديه استاذتنا واستاذ الباثولوجي، وانا سعيد جدا بجد بوجود الدكتوره ناديه مختار اللي بنقول اللي هي انشات المودرن باثولوجي في جمهوريه مصر العربيه كلها. فانا بشكرك الدكتوره ناديه على وجودك.
I would consider this patient as metastatic, whatever is the result here. The patient is metastatic and she required for myself, require treatment until progression or unacceptable toxicity. She should receive CD46 and hormonal treatment until progression. Any comment?
If we consider this metastatic disease and in CR or long-term disease-free survival, I am asking about who shouldn't receive from metastatic ER post-tumor the CDK as a first line. We have to segregate, at least on local guideline. So I think if we will segregate and we will choose some low-risk patients that shouldn't start with CDKI, these patients will be one of them. I don't know.
The problem is that we don't have this segregation like in HER2 positive. It depends only on the side effects of the CD46. We don't have yes, I know, it's just a scientific debate. But if you are going to local guidelines, I'll go for AI until progression, also not only for 5 years or 10 years as in the adjuvant setting. Because I expected for this patient to relapse. We are just extending the progression-free survival for this patient, and we are not expecting cure as in very early breast cancer. Any comment? So we all agree that oligometastatic bone can be treated radically. This was the second question. Go to the third case. معك انت الورقة يا محمد. اتفضلي.
Sorry.
Thank you for the presenters and the last case for the MDT today.
Regarding the follow-up of this patient, radiologically, what you want to do for her? Every month, every 6, you will do mammogram, or you will go for MRI because it was lobular, or which you will follow the case?
Very good question, and I need to hear. Excellent question. For me, I'll go for the ده اللي عادة بنعمل الأول CT every 3 months as a very metastatic disease just to be sure she was not progressed. And then after 2 years, if the patient is still in remission, I think we can extend the period of the follow-up to be every 6 months. But this patient requires evaluation radiologically, periodically, not like the early breast cancer, just mammography yearly. دكتورة شو
يعني هو دكتور أمل was asking about the follow-up of the breast, not of
the bone.
The follow-up of the breast, any يعني patient who has underwent an operation for breast cancer is followed up like any other normal individual annually.
Okay.
With a mammography and we might complement with an ultrasound.
طبعا it's still debatable, but case by case, if this patient every year we are doing CT and she's still in regression or CR, yes, she deserves to go for mammography, I think annually. But if she progressed, then the mammography.
I would have to check on.
Not every 6 months.
Every 6 months for the metastasis.
Okay. And no PET CT in the following.
مش عايزه ابقى انا بس اللي بجاوب انا
معلش if I have a baseline study I should follow on the baseline study to see the difference I follow up on the same baseline study that I
depend and you are treating this patient as a radical. This is a very unique case, but in general follow up of a patient with cancer breast, if it's non-metastatic, the guideline called for annual mammography till year 75 until the life expectancy less than 5 years, and just the mammography or pelvic ultrasound for patient who is receiving tamoxifen if the patient is symptomatic. For metastatic disease, it depends on the modality you start with. As I agree with you, you start by CT scan and bone scan, you continue with CT scan and bone scan. You start by PET-CT, continue with PET-CT. The value of mammography in metastatic breast cancer case is debatable. We don't have the answer for this patient.
Thank you very much. And so I will go to the last case for today. And the case will be about the management of recurrent breast cancer. Actually, it's a very hot topic about how to manage the breast and how to manage the axilla if you do sentinel lymph node or you do axillary clearance, and how to manage the recurrent sarcomas and recurrent carcinomas. So it's a very big issue, and it's my pleasure to introduce our presenters, Dr. Mahmoud Hassan, Dr. Imam Fakir, Dr. Safi Hosni, Dr. Iman Sobhi.
Okay. Our third case, a female patient, 35-year-old, presented at Bahia at September 2019, medically free, with negative family history, presented with a left breast lump dated 3 months ago. Clinically, T2N0 with a mass at left upper outer quadrant 2 o'clock, freely mobile, firm, about 4 by 3 centimeter, 6 centimeter away from the nipple, with no palpable axillary lymph node. For completion of the triple assessment, ultrasonography and true cut biopsy requested.
Her mammogram revealed the left upper. Her mammogram revealed the left upper outer quadrant, the lesion of intermediate density and ill-defined margins. Confirmed by the ultrasound, showing a large hypoechoic lesion with ill-defined margin. It's probably malignant lesion, and her lymph nodes were non-specific, they are not pathological, with a preserved fatty hilum. The true cut biopsy was taken from the lesion.
The biopsy showed cords and trabeculae of malignant ductal epithelial cells. It was high grade, showing poorly differentiated cells with poor ductal differentiation, high mitotic activity, and active mitosis. There was no associated lymphovascular embolus or DCIS, so it was diagnosed as invasive duct carcinoma grade 3. ER was totally negative. PR showed low positive reaction in 15% of the tumor cells, and HER2 was totally negative.
Okay. After MDT consultation, a contrast sonography requested, also a CT scan requested.
A contrast enhanced mammogram was done. Her 2D image revealed the confirmed the lesion. The contrast enhanced mammogram showed the lesion shows heterogeneous enhancement, which confirmed the malignant findings, given also PIRADS 4. The CT was done for staging. It confirmed the presence of the mass. And there were present a prominent axillary lymph nodes, and there were prominent interpectoral lymph node about 3 millimeter in size.
Okay. Then what next plan for her treatment? MDT decision for this patient was to start a neoadjuvant chemotherapy regarding clipping after the first cycle. Before reaching the last cycle, the patient noticed a new lump in the same anatomical or clinical position of the her tumor, despite complete disappearance of the tumor clinically during chemotherapy.
Here the patient performed a mammogram. Actually, it was requested in a time not after the last cycle. It was before the last cycle. We performed her the mammogram, which showed a regression regarding the lesion size with the clip scene inserted. And it was reported as a partial, as a good response for the therapy, with no newly developed lesions, as the patient was claiming.
The patient ended her neoadjuvant chemotherapy with a good tolerance. Then she had a follow-up contrast enhanced mammography and ultrasound.
The patient performed her post-neoadjuvant contrast-enhanced mammogram. Here, the lesion showed marginal enhancement with the clip still seen, confirmed by the ultrasound with the central areas of breaking down. Yet the lesion increased in size, but the response, it was documented as a good response. The lymph nodes here became pathological to the muffled hilum. And this was confirmed by the surgery as they referred to us saying that they now feeling a lymph node. Here's comparing the pre-neoadjuvant contrast enhanced mammo with the post-neoadjuvant. We can see, yes, an increase in the size, but we consider it responding because it's showing areas of breaking down, which indicates the viability of the lesion, the less viability of the lesion. A follow-up CT chest and abdomen was also requested, which showed confirmed the presence of the lesion, and still noted interpectoral lymph node, and they were stationary in size, no newly developed lesions. Here, the 3 mammogram, I wanted to confirm the lesion size. It was the first, this was the first presentation of the patient. Then this was during the neoadjuvant chemotherapy, and this was post-neoadjuvant chemotherapy. We can here recognize the regression and the progression of the size.
Okay, to summarize, this patient, a triple negative, 33 female patient, started neoadjuvant chemotherapy, then showing a good response clinically and radiologically. Then during the chemotherapy, her 7th cycle progressed in size, and noticed on CT staging an interpectoral lymph node. Noticed clinically initially was node negative, on chemotherapy turned positive. So a new CT requested and MDT discussion for this case. In spite the mass increased in size and lymph node turned positive, but no newly developed lesions in the follow-up CT, so not considered metastatic. Stage T2N1 and scheduled for surgery, left wide local excision and axillary clearance. The pathology.
Okay, the patient underwent wide local excision and axillary clearance, and grossly there was a rather defined soft mass, 3 by 3 centimeter. The least surgical clearance was the deep one, 1.2 centimeter. It was capacious. Microscopically, it was diagnosed as invasive duct carcinoma grade 3. Viability was 70%. No DCIS or lymphovascular emboli detected. T2N0 post-chemotherapy. Lymph nodes were negative, 0/10, and the margins were free. Residual cancer burden class was 2. Here we can see the histological pictures. Yes, here is the residual viable cells seen as a large confluent groups of viable tumor cells. And this part, we can see the partial response in the form of inflammation and necrosis. And the higher power pictures show the poorly differentiated, highly atypical cells with active mitosis.
Okay, then the patient received their adjuvant treatment, post-operative radiation and tamoxifen.
صوت شويه يا احمد. قرب المايك.
So the patient received their adjuvant treatment, post-operative radiotherapy and on tamoxifen, and follow-up 2 months after surgery. Presented to the clinic with a left subpectoral palpable lump, ultrasound showing an organized subpectoral hematoma, and follow-up. Then after 2 months, the patient came again with a newly developed mass. By examination, it's mass away from the operative bed at the lateral edge of the pectoralis muscle, about 2 centimeter. Ultrasound, the previous one showing it's a hematoma, but this a new lesion is away from the from the hematoma. Okay. Aspiration requested. تكلمي؟
جراحين بص مفيش فايدة.
تقول المكان بتاع
والله هيماتوما.
Okay.
It was the same lesion. Follow-up after 2 months, it was first an organized hematoma, then given follow-up after 2 months. It was still the same lesion, but we had a failed attempt of aspiration. Another follow-up after 2 months, the patient came again. Or after 2 weeks, sorry, the hematoma become more organized. Here we did an aspiration. It revealed a bloody aspirate and there were no malignant cells. So here it given another follow-up after 2 months. And the patient here came with the same lesion, but with inflammatory signs, as we can see here, diffuse interstitial edema, overlying skin thickening. And it was given also another follow-up. A CT was requested. Here we can see the organized hematoma, the sequelae of this hematoma at the operative bed, but away from the operative bed was this lesion. This lesion was interpectoral, showing marginal enhancement. So this lesion is apart from this lesion. This is one and this another one. We suspected this lesion and we asked for a true cut biopsy from this lesion.
It was proved to be a recurrent invasive duct carcinoma with the same grade 3. We can see the sheets of malignant large polymorphic rounded cells. Cytokeratin was done to confirm the epithelial nature of the tumor cells. There was also wide areas of necrosis. The high power field show poorly differentiated epithelioid cells, and it showed the same biological behavior, typical biological behavior as the biopsy were done.
After the biopsy, staging recommended.
We performed her a new mammogram. It was request for her a new sonomammogram and CT for restaging. The mammogram revealed the lesions confirmed by the ultrasound, this large ill-defined lesion showing areas of breaking down. And the CT confirmed these findings, where the lesion is subpectoral, interpectoral, so showing the same criteria.
Patient received, actually we introduced the case to the MDT and the patient was surgically inoperable. So we started chemotherapy as a query neoadjuvant versus metastatic. But unfortunately, we received many lines of treatment with no response but progression.
Okay, another follow-up CT study was done. Here we confirmed the presence also of the lesion. No newly, just running a stationary course, and no newly developed lesions. From that date, the patient performed a follow-up CT about every 3 months with changing the line of treatment. After 2 months, also the lesion increased in size in comparison to the last study. It was progressive. They changed the line of treatment, then for 3 cycles again, then follow-up CT chest again was requested, which also showed the lesion to increase in size in comparison to the previous study.
We presented the case to the radiotherapy department and they approved to receive radiotherapy, but they have a consensus that the patient is not metastatic. We will give the radiotherapy as a line of improvement, but not as a metastatic disease. So she received radiotherapy, then she received Xeloda as a 4th line of treatment for 3 cycles.
Another follow-up CT study was done, which also the lesion increased in size, running here a progressive course compared to the previous study. In this study, there was a new lesion appeared in the SQ rectal fossa, deep pelvic lesion, quirinodal. And it was documented as a progressive study.
Then the case consulted again at the MDT for possibility of resection of the recurrent breast mass and for a biopsy from the deep pelvic mass. The mass clinically and is irresectable, and the pelvic mass is inaccessible to be biopsied, and received another line of treatment. And follow-up CT.
The lesion also increased in size in comparison to the previous study. And the deep pelvic lesion also increased in size. At this phase, it was requested for a biopsy, but unfortunately, it was inaccessible for biopsy.
So can we reach to the conclusion of the final?
The patient still changing the line of treatment, and finally, she is working till now in a palliative maintenance treatment, and nothing.
Okay, thank you very much, Dr. Amani. I think the recurrent breast cancer is a very, very hot topic, and it needs a long entity for itself. So, Dr. Amani.
أنا ليا كم سؤال. الأول
It is a recurrent. This is the question. This is not a recurrent.
هي كانت موجودة من الأول.
I think so.
Interpectoral lesion. Okay.
I think it is was.
طب سؤالي ليه كان في راديولوجيكالي كان في بروجريشن في الليمف نودز وبعد كده باثولوجيكالي ليمف نودز نيجاتيف؟ يعني في الفولو اب بري اوبراتيفلي افتر اند اوف نيوادجوفنت كيموثيرابي كان كومنت راديولوجيكال ان في افاس ليمف نودز وشكلها بوزيتيف.
يعني percentage of false results with the ultrasound. يعني هي الليمف نود كانت morphologically في الالتراساوند it looked pathological بس small size وكده ف it might be يعني مثل لا هو لأن ال question to the pathologist should يعني احنا for us in imaging we consider viable cells those which the percentage of the lesion which uptakes the contrast. Should I look at this lesion, the original lesion, have يعني the amount of solid component has decreased, it has become cystic, and it increased in size. Should we consider this increase in size aggressive tumor that has يعني outreach vascularity, so there is central breaking down with increase in size, or should I consider it response, so there is less viable tumor in the cells? عشان في البوست اوبراتيف طلعت 70% viability. يعني for us as radiologists I would say I cannot assess. لا I cannot assess. لأن you never know is this breaking down or is it reduction in the amount of viable cells.
دكتورة أماني كان
in radiology we comment only as a progression is if it is more than 20% sizable, so I will put it as a progressive course.
The way we assess the lesion.
معلش كومنت بس اكومنت على حاجه. هي العينه تقريبا كانت تريبل نيجاتيف، ما فكرناش ان احنا ندي زيلودا بعد السيرجري. انا اخذت تاموكسفين ولوكال راديوثيرابي.
The problem is with the definition of the triple negative, and this is a trap for all of the oncologists. The ER is negative and the BR is 15%. And we don't know, should we consider the patient as triple negative?
Yes, I was just going to comment on that. This should have been treated as a triple negative tumor from the start. Yes, and it is well known that the low, but we don't express them as 15%. We put the score of 1/8 or 2/8. If that's 1/8 or 2/8 Aldrich scoring system, then 5% or less, it has to be considered negative.
The definition of the triple
Not
negative
negative, but negative in a way
In
that
behavior.
it will not respond.
in behavior.
دكتور ماهر.
بالنسبه بس دكتوره ناديه معلش كومنت. Do you believe there is patient with ER positive and HER2 negative, ER negative and BR positive? Do you believe that there is we have a patient? Because there is a debate for years that there is no patient with ER negative and BR positive. And if it's BR positive, this is not true. And I think the recommendation usually to treat the study several times because this is unusual to find a patient with ER negative and BR positive. Second comment about the percentage of BR. Now there is some data that patient with PR or ER less than 9% considered as negative, but this till now this is not the standard. This is what is called low ER or low PR. But in these patients, you treated. This is by book is not a triple negative, by book because the PR is 15%. But if you believe this is triple negative, I agree with Dr. Amani. So at that time there is a role for adjuvant capecitabine because patient.
Okay.
Yes, if I may, yeah, I mean, the positive PR with negative ER should be an extremely low occurrence. The incidence should be very, very low. And as you rightly said, some people believe that they don't exist, this category doesn't, and that this represents a false positive PR. So when we get a situation like that, we would repeat both the ER and PR to make sure that actually your PR is truly positive. It should be a really, really small proportion. If it is more than, people say it shouldn't exceed 1% of all your cases. If it is a recurrent disease, that's a QA issue, and you really need to look at your staining. Yeah, ER, the ASCO-CAP guidelines recommend this new category of ER low, PR low, which is 1 to less than 10%. And these are thought to be biologically behaving more like triple negative. And in this particular case, I would have repeated ER, PR, and HER2 on the residual disease to see if this is still ER negative PR, because it could be triple negative on the residual disease, which is more reflective. So yeah, tricky one, but yeah.
Should we consider BRCA testing for this case?
Dr. Nadia?
Yeah.
Dr. Nadia, have a comment?
Yeah, I do have. In fact, it shouldn't be just a technical defect. I mean, you could repeat and repeat, and the result is the same. With inborn controls in the tissue, we are sure that the result is sort of right. But still, all cases that show negative ER and weak PR do not respond, whichever explanation you can put. But they don't respond as hormone positive cases.
So
we are just falling the trap of the definition of the triple negative, and we are all heterogeneous when we are treating our patients. For me, for any patient less than 10% ER or PR, I treat her like triple negative, and which is not going to the pathological CI, I'll go with capecitabine. Other clinician will refuse to do this because the definition of the triple negative in the guidelines is less than 1%. Although most of the studies using the endocrinal treatment usually use the definition of 10%. They don't take the patients with 1%. They take the patients 10%. 10%.
Okay.
So this is a trap.
So from the surgical point of view, for this nodal disease or nodal recurrence in the subpectoral part, and after complete axillary clearance with 0/10, do we have a surgical rule for re-excision of the nodal disease in imaging, or it is a systemic treatment?
Well, very nice case. Very nice case. هم 4 أسئلة. هو is it actually a recurrence or residual disease؟ صح. نمرة 2 ايه البريبكتورال ماس دي؟ بريبكتورال ماس دي what is this؟ What is this peripectoral mass؟ residual breast tissue, interpectoral lymph node. السؤال الثالث is it actually triple negative؟ I totally agree with you. بالذات ان عندنا فاكتور حلو قوي بنناقشه دلوقتي necrosis. What about يبقى هم 4 حاجات عشان MDT نعرف نوصل منه لحاجه. انا بحلله ل 4 main topics. Recurrence or not, prepictural, كانت triple negative, وايه ال value of necrosis. احنا assessed adequately the value of pre-treatment necrosis في التيومر بالذات في triple negative. And we have assessed the value of post-treatment tumor necrosis برضه in triple negative. الحالة دي ماشية كلاسيك مع triple negative بلا أدنى شك. I totally agree إن ممكن يبقى فعلا technique error or something. that should be revised. Prepectoral lymph node should have been excised. Subpectoral, retropectoral, retropectoral nodal disease. Triple negative by presence of tumor necrosis. Repeat your tissue sampling again.
This is not a recurrence.
Dr. Maher,
This is a Trotter's node that has been
Yes,
always there.
yes.
We haven't opened we don't open the space between major and minor to remove the node, Trotter's node. So this is something that has been always there. It has been left. It's not left by mistake. It's left because when we do the clearances, we don't go between major and minor.
But we should palpate this intraoperative.
But sometimes it might be.
That's what they do in the EAU.
Yes, but it might be small. You might not have
Yes,
felt
sure.
it. So it might have been there. And this is somebody that has progressed on chemo. I would have argued in the MDT they should have had their capecitabine, but this is something that you will never win against. This is somebody that will have metastatic disease, unfortunately, and will not do well, whatever you do.
Okay, I'd like to raise some points, Dr. Maher. If you allow me, first of all, we should consider that this patient has 2 indications for BRCA gene detection. This should not be forgotten. I know that this is not available in all centers, but still we have to know this. She's 35 years, and I do consider her as a triple negative. Second part, I don't believe that ER negative, PR positive disease do exist. Most American pathologists don't consider this type already exists. So it should be treated, I think, as a triple negative. I think this is residual, as Yazan has just mentioned. The part of is it operable or not? This should be a senior decision through the MDT. And I believe, although I believe that the patient, by the end, she will progress again, but I think she was operable at one time, and she should have operated at that golden time. Otherwise, we don't know how much this will increase until it might fungate, and at that time it will be horrible for the patient. I believe she was a candidate for surgery at some point of time, although meanwhile within 6 to 9 months she will develop this.
I think the decision for surgery was not only for the resectability or not, but as the doctor mentioned, this was not resectable at the presentation, but it's not a matter of resectability, as Dr. Yazan mentioned. It is the Rotter's nodes, the axilla was complete clearance, so they considered it for the systemic treatment to deal with. Yes, and after the recurrence, it is progressed from chemo. So
not even palliative surgery.
Maybe we have a role for palliative surgery, but I think it's with progressions were more fixed. So it is.
We would agree at the end after fungation of the mass.
Okay.
I had that very similar lady 8 years ago. Exactly the same story.
Okay.
Wide local excision. She nearly had complete response on chemo. By the time I took the tumor out, what was again 3 centimeters, cleared the axilla. There was lots of positive nodes in the axilla. She had an axillary recurrence within 6 weeks. It was still small, and I went back and took all that out, but she still died 4 months after that from her liver mets.
So it is aggressive disease, yes, rather than local control. It's a systemic aggressive disease rather than local resection. I think if we would go for even local resection, so it will recur very soon because the tumor is very, very aggressive, as Dr. Yazan, it's your concept for the.
But if it's for local control, you need to go back early. You cannot take this. This will be a nightmare.
Okay.
I have 2 comments. One is about the PR and the low ER or the PR. These tumors, even the low ER ones, they are proved to be genetically very similar to the triple negative, genetically and behavior-wise. So we're not talking about a result that is not right. It is probably very right, and the PR is positive.
What's the value of
but when it's
by
low,
low? 10%,
low, it's less than 10%. Less than 10%. The result is right, it's validated, we always have controls on the slides. So even if it's right, these tumors are genetically very, very similar to, genetically and behavior-wise, very similar to triple negative breast cancers. The other thing is, why are we not trying PDL1 in this case?
So
Since FDA approved pembrolizumab for the early, yes.
Can we have a conclusion about the session?
We can consider PDL1 if we have. If we have an immunotherapy, she will go for testing for BDL1, and she's positive, she can receive. I need to
BDL1
hear
is
from
indicated in patient with sure triple negative. The study is very clear. The definition of less than 10% was not in the study. So you have to follow the study. It's a very expensive treatment, talking about 100,000 per month. So this is not an easy treatment. Yeah, it's more than 100,000 per month.
So
my
the-
comment
Can-
here
can I-
about Dr. Amal when asking a question, which I think is difficult. When you use the ultrasound after chemotherapy, by radiology, it's increased in size, but this is due to necrosis. And also there's a new lymph node appeared. The RECIST criteria only assess the longest diameter of the lesion regardless of the function. And this is also, we see this problem with the HCC, and we have a special staging classification for that. So this is the problem, you don't assess the function except if this patient, for example, had PET-CT before and PET-CT after, maybe assess you. But theoretically speaking, if the tumor increased in the shortest diameter, this is a progressive disease. This patient should be go for mastectomy and not for conservative treatment by guidelines.
So it's very.
This is, I have two questions for the oncologist. When they say this is a recurrent disease, okay? So from the beginning, this is a recurrent or this is a residual?
No, it's
The
a
other
resi-
question, Dr. Rasha, really, she will answer my question. Again, we had to put another guideline for term progression. Because by this way, this patient, it is progress in size or just the necrosis, it make it as if it is progress in size.
Yeah, patient goes for contrast enhanced, and there were no enhancement in the lesion.
So this was my question.
She did something like
It's
PET-CT.
a rapidly growing tumor. It outgrows its vascularity. So يعني normal, يعني it could be progressing, بس فيها breaking down due to the rapid growth.
My question is, the patient showed that the newly developed axillary lymph node, and this could be considered as progression. It was right to go for surgery, or she should go for biopsy of axillary lymph node, and if it's progressed, she should receive another line of chemotherapy.
So I think.
What do you think?
I think Dr. Amani, in this case, will know the endless discussion. So I have to have a recommendation from Dr. Amani about the conclusion of this case. So it's a very difficult and tricky one, and it's an endless discussion. So I think Dr. Higazi focused about main points: it's recurrent or not, or residual disease, and Dr. Yazan responded to this. It is inaccessible for surgery. Actually, it is away from the surgical field, and it is for systemic treatment, but in aggressive tumor behavior like triple negative. And sometimes there is no response, but the definition of triple negative is debatable. So finally,
Can I just add one word? KI-67. KI-67 was not done.
Yes.
And, I really recommend KI to be done routinely. If a tumor has more than 50% proliferation index, that's a sure evidence that it is a very aggressive tumor, and that probably it will respond beautifully to chemo.
Thank you,
The
Dr.
tumor was grade 3, Dr. Nadia. Do you think KI-67 will add to this information because it's aggressive from the start?
Morphology is not biology.
Yes. Okay.
Sometimes we cannot find the final conclusion to some cases. It is case by case and for MDT.
I'll start with the first conclusion. What should we do after progression on the neoadjuvant chemotherapy? Would you go for a second line or to go for surgery? Second line chemotherapy. Who would agree for second line chemotherapy?
Can we have a vote? It is inoperable.
It's operable. If it's operable, go for surgery. The medical oncologist agree. Okay. Okay.
So if when it is operable, even if there is second line, we'll go first for surgery. Okay.
Second question.
Final question about
You want to ask about the axillary.
the management of
the
the axilla
axilla-
after axillary clearance and the nodal recurrence. Can we go for surgery for the nodal recurrence first, or we can go for systemic treatment as it is a systemic disease? Actually, we do our job by clearance.
So if it's a local control issue and you think it's a local control issue, you control it locally with surgery. But
Yes.
if you think it's a systemic disease, so it depends on the type of pathology you have and on the staging, then you start with the chemotherapy. So if there is an indication for chemo, you do the chemo first and then clear. But if it's a small early local recurrence and excisable, just go for it first. And
Yes.
then you look at that.
So if it is feasible for surgery at any time, you can go for surgery for this time. Thank you very much. Thank you very much for all, and we will close the conference now. دكتور محمد اتفضل، دكتور خالد، دكتور اماني اتفضلوا. احنا بس هنفضل 10 دقايق مع حضراتكم، هنختم المؤتمر وبعد كده ان شاء الله نروح على العشاء. دكتوره رشا.